Applied and surgical and clinical anatomy of the kidney. Renal stone. All urinary stones are very common condition, especially renal stones. Renal stone occur in the calyces. Think with me. The renal stones are much more common on the upper calyx or in the lower calyx. Sure, urine is a concentrated solution containing calcium oxalate, phosphate, urate crystals. And if the urine passes rapidly, there is no chance for this crystal to settle down and to precipitate and to form stones. From all these calyces, where is stasis occur? What is the calyx liable for stasis? Slow passage of urine. In the upper calyx, the urine passes with gravity, very rapid. But in the lower calyx, the urine ascends against gravity. Therefore, slowest urine flow occur in the lower calyx and liability for stone in the lower calyx. Therefore, the most dependent calyx is the most liable for stasis, precipitation of crystals in the urine leading to formation of stones. Malignant tumor in the kidney. Think with me. Malignancy in the kidney spread directly to the surrounding structure, or by lymphatic spread, or by blood spread. Sure, we all know that malignancy spread by all these types, direct, blood, and lymphatics. What is the direct spread of malignancy in the kidney anteriorly? What is the spread of malignancy directly posteriorly? Sure, this is guided by the relation of the kidney. Example in this picture. Malignancy in the anterior surface of the right kidney is spread to what? To second part of duodenum, or to the right suprarenal gland, or this all part is related to right lobe of liver, or here is the flexure, which is right colic flexure. Malignancy in the anterior surface of the left kidney is spread to left suprarenal gland, is spread to body of pancreas, to splenic vessels, to spleen. This is the left kidney. Is spread to the spleen, is spread anteriorly to the stomach, to the pancreas or splenic vessels, to the transverse or descending colon. Therefore, actually we take the relation, and the relation is very important in surgery because it represents the direct spread of malignancy. طب malignancy in the posterior surface of the stomach is spread to where? To the posterior relation, to the diaphragm, psoas major, quadratus lumborum, and transversus abdominis, or the structure separating the kidney from this muscle, to a subcostal nerve or vessels, to the iliohypogastric or ilioinguinal nerves. Lymphatic spread to the kidney, guided by the lymphatic drainage of the kidney to the hilar, then to the para-aortic lymph nodes. Blood spread to malignancy in the kidney, as usual. The malignant cells enter with the venous return to the lung, bone, brain, and liver. any blood metastases from any malignancy is 2L, liver and lung, and 2B, bone and brain. The loops of the liver, the loops of the kidney. The loops here of this kidney. In early fetal life, and early infancy, the loops of the kidney are represented on the surface and appear on the surface, but disappear later on with progressive age. In some cases, this occurs. Adult kidney with this. What is this? Persistence of the fetal lobulation. Therefore, the kidney is normal, has a smooth surface, but if there is persistence of the fetal lobulation, you will find the kidney lobulated like that. The suprarenal gland. We said that very important clinical importance, that easily we can do nephrectomy alone, removal of the kidney, or suprarenal adrenalectomy, removal of suprarenal gland alone, without any damage of the neighboring kidney or suprarenal gland. Why? The perinephric fascia surrounds the suprarenal gland and the kidney, but the perinephric fascia send a loose septum of loose alveolar connective tissue between the suprarenal gland and the upper ball of the kidney, and the surgeon very easy during operation can enter his finger to do blunt dissection, separating suprarenal gland above. You can remove suprarenal adrenalectomy alone, and the kidney below you can remove nephrectomy alone. We should take care that the kidney moves up and down during two conditions. During movement of the diaphragm, during respiration, or during a change of position. When you're lying flat and you stand, the kidney with gravity can move within a vertical axis within 2 or 3 centimeters. The kidney. Never the normal kidney cannot be felt clinically. If you try to feel a kidney, the normal kidney cannot be felt, except the lower ball of the right kidney. Why? We said before that the right kidney is lower than the left kidney, and the lower kidney, the lower ball of the right kidney, can be felt normally, but never the left kidney. The left kidney is only felt if enlarged pathologically. The two layers of the perinephric fascia are almost separate inferiorly and only connected by loose alveolar connective tissue and fat. Therefore, any blood from the kidney, in case of ruptured kidney in any accident, or in perinephric abscess infection, pus or blood from the kidney only has one way, downward into the pelvis. From the posterior relation of the kidney is closely related to muscles. Any perinephric inflammation around the kidney will irritate this muscle, which is called psoas major muscle. Irritation of any muscle produce contraction and spasm of this muscle. And we sure all know that the psoas major is the main flexor of the hip. This leads to flexion deformity in the hip. And therefore, this patient may come to you with flexion deformity of the hip. And if you try to make extension of the hip leading to spasm in muscle, and you try to stretch this spastic muscle, stretch on a spastic muscle leading to exaggeration of pain. Therefore, it is very common in inflammatory disease around the kidney to see psoas spasm with flexion deformity with painful extension. Surgically, if you want to make surgery in the kidney, do you want to open and expose this kidney anteriorly better or posteriorly? I open the anterior abdominal wall anteriorly. On the right side, the liver occupy the right side of the abdomen, and surrounding structure, colon, duodenum. This is very difficult clinically, and there is the ability to injury all this structure. On the left side, you want to open anteriorly here, you will find the stomach, spleen, colon, folds of peritoneum, very difficult. Therefore, to reach the kidney clinically, this is the best. To open from the back of the patient, to open posteriorly. To open posteriorly, only we open muscle, which can be sutured at the end of the operation. But when you do posterior approach, which is the usual approach, never forget to preserve these nerves and vessels. There is the ability to injure subcostal nerve and vessels, iliohypogastric and ilioinguinal, which should be preserved and avoid their injury. We only open anteriorly, anterior approach from the anterior abdominal wall to reach the kidney if there are 2T. Because in these 2T, we need exploration all over the abdomen. What is the 2T? Tumor and trauma. If there is, you diagnose ruptured kidney due to trauma from the anterior aspect, leading to ruptured kidney. Ruptured kidney from trauma in the anterior aspect. It is usually associated with ruptured liver, which is anterior to the kidney, and ruptured colon, which is anterior to the kidney. Therefore, in trauma, we need exploration to open the abdomen and to deal with all injuries, not dealing with the kidney only. On the left side, it is much more common than rupture left kidney is rupture spleen. Therefore, the exploration from the anterior abdominal wall on the left side to expose the spleen, the stomach, all the surrounding structure to deal with any injury. Therefore, usually exposure of the kidney is posterior extraperitoneal approach. This is the favorite approach from posterior in all urinary tract operations, because the urinary tract containing urine. If you open the urinary tract from the anterior aspect and you open the peritoneal cavity, if one drop of urine enters the peritoneal cavity, this contaminates the peritoneal cavity, leading to fatal peritonitis. We only expose from the anterior aspect the urinary tract in 2T trauma and tumor. And exposure always posterior extraperitoneal approach to avoid peritoneal contamination. Renal transplantation. It is very common nowadays to do renal transplantation for hopeless renal function and patient with renal failure. The treatment of this patient is to take a kidney from a recipient and to put this kidney in the donor. The kidney is implanted in the iliac fossa. The kidney is implanted in the iliac fossa here. And the renal vessels are anastomosed to the near vessels, external iliac vessels. And the ureter is anastomosed shore below to the urinary bladder. Why in the right iliac fossa? Because the kidney is not supported normally from below due to perinephric fascia which is open below. If you put the transplanted kidney here, the kidney is not supported from below with liability of traction on the anastomosis of the vessels. Therefore, in the iliac fossa, the kidney is supported and the renal vessels, no traction on the renal vessels, and the urinary bladder is very near the anastomosis, and in transplanted kidney, the kidney is put in the iliac fossa. Why we take this segmental blood supply of the kidney? We take segmental blood supply of the kidney, which is the principle of partial nephrectomy. Pathology in a certain area. We can remove only the diseased segment of kidney by ligation of the segmental artery and the diseased segment only, leaving the healthy tissue or the remaining healthy tissue for the patient. Therefore, this is very important and the principle of partial nephrectomy. Renal entrapment syndrome. What is the renal entrapment syndrome? This. The left renal vein is entrapped here. Entrapped here and compressed here in this interval between the aorta posterior and superior mesenteric artery anterior. This is a lateral view. Aorta posterior, superior mesenteric artery anterior. And in between, in this interval, there are two structures. The left renal vein and the third part of the duodenum. Here, the third part of the duodenum, compressed in the same interval. This results in compression of left renal vein leading to congested kidney. Congested kidney leading to pain in the loin. Loin, which is the area between the last rib and the iliac crest, the site of the kidney. And there may be hematuria, blood in urine. And this important vein drain here, which is the left testicular vein in male. Therefore, this entrapment leading to congestion in the left testis leading to testicular pain. And the congestion in the venous drainage of the left testis leading to dilatation, elongation, and tortuosity of the venous drainage of the testis. Simply varicose veins. Varicose veins in the bambiniform plexus which drain the left testis in the scrotum. Varicose veins in the left side of the scrotum is called the left varicocele. And the condition may be associated with nausea and vomiting. Why? Due to compression of the third part of the duodenum, leading to distension of the proximal part of the duodenum, leading to nausea and vomiting. This is called renal vein entrapment syndrome. All these symptoms due to compression of left renal vein and the third part of the duodenum in the interval between aorta and superior mesenteric artery. Radiological visualization of the kidney by what? First of all, and the most simple, is plain X-ray. Plain X-ray abdomen shows the bones and show gases in the colon, and may show what is this? Radio opaque stone in the pelvic calyceal system. How you know that it lies in the pelvic calyceal system? It takes the shape of the renal pelvis and branch in the calyces. Therefore, this is a stone in the left pelvic calyceal system. Or we can visualize the urinary system and the kidney by this abdominal ultrasound. And this is the structure of the kidney as we see. Cortex, outer cortex, and the inner medulla, and in the center is the pelvic calyceal system. What is this line? Actually, ultrasound is associated with the system of computer system. Therefore, we see the picture of the kidney in ultrasound, and the computer will make this line, and they measure the length of the kidney, and measure the transverse diameter of the kidney, and show the thickness of the kidney, to show the size of the kidney if enlarged in pathology or not. We can see the pelvic calyceal system by give a dye intravenous, and this dye pass in the bloodstream. The kidney excretes the dye in the pelvic calyceal system. This X-ray with dye is called IVB, which is abbreviation of intravenous bilography, because it shows bilo. Bilo means renal pelvis. Shows the pelvic calyceal system. And this is the anatomy of the pelvic calyceal system. This is the renal pelvis. Open in the renal pelvis 3 major calyces. And the major calyces receive the minor calyces. And sure, downwards the dye descend, show later on the ureter, as we will see in the anatomy of the ureters. This is called the IVB, intravenous bilography. Graphy means take a picture. Bilo means renal pelvis. Therefore, picture to the renal pelvis is intravenous bilography. We also can visualize the kidney by this. What is this? This is CT scan, computerized tomography. Computerized tomography, the patient lie here and enter in this equipment, which take X-ray sections in the patient. This is a section in the abdomen. Show what is this vertebral column, vertebrae, and the paravertebral gutter. And in each paravertebral gutter there is left kidney related to spleen, right kidney related to liver, and this is anterior structure passing in front of the left kidney is the pancreas. And this triangular structure medial to the left kidney is the left suprarenal gland. And this is the aorta. This is the inferior vena cava. We can also visualize the kidney by MRI, magnetic resonance image. Simply, for your level, what is the difference between CT scan and MRI? In most cases, in CT scan, the bone appear white or black. This is the vertebrae and this is the ribs. The bone in CT scan appear white. But in MRI, the vertebrae here, the vertebrae appear black. And the fat appear white in MRI. And in MRI, we can take picture in vertical sections, sagittal section and vertical sections, or horizontal sections, like that. This is MRI, vertical sections in both kidneys, and this is transverse section, MRI, appearance of the kidney. The renal pelvis may be extrarenal or intrarenal. How? This is very important. In the pathology, you will hear about two different types of pathology in the renal pelvis. These two pathological types depends upon the renal pelvis. Is intrarenal or extrarenal? The renal pelvis here, this is the end of the kidney, and the renal pelvis is outside the kidney. Sometimes the renal pelvis may be inside the kidney and comes out from the renal sinus and the hilum, the ureter directly. Therefore, the renal pelvis may be intra or extrarenal. This is extrarenal pelvis, which is the typical. Embryologically, the kidney is formed in the pelvis, and it has a posterior convex border and a medial concave border containing the hilum. With progress of development, the two kidneys ascend upward to the abdomen with a process of rotation to reach the adult anatomical position. Failure of ascent of the kidney leading to kidney at a lower level, not at the level of T11, T12, L1, 2, 3 vertebrae. Kidney congenitally at a lower position with a straight ureter is called ectopic kidney. Like this. This is a normal kidney in normal position, and in investigation, ultrasound or CT scan or MRI or IVB, this kidney present here with short straight ureter. This is ectopic kidney, which should be differentiated from this. What is this? This kidney originally normal, but fall down, and this called the nephrotosis due to loss of support of the kidney. How you lose the support of the kidney? Fatty patient, and the kidney is supported with about 10 kilograms of fat. By diet and by regime, the patient loss much weight, and the supporting fat becomes less, and the unsupported kidney fall downward. Or very important point in maintaining the kidney position is the increased intra-abdominal pressure. Patient with much increased intra-abdominal pressure, and the intra-abdominal pressure suddenly fall. In whom? After labor. Marked increase intra-abdominal pressure, the kidney is compressed and in place, but after labor, sudden decrease in intra-abdominal pressure, and the anterior abdominal wall is lax, and due to sudden fall in the abdominal pressure with fall of the kidney, leading to nephrotosis. What is the difference between the two? The two has the same position, but congenitally ectopic kidney has shortest ureter, but in nephrotosis there is kinking, coiled ureter. You may find this. What is this? Two kidneys are fused together in the middle line by tissue, renal tissue called the isthmus. This isthmus always below the level of L3. Why? This kidney is called horseshoe kidney, and it maintains the original anatomical life in the fetus. It has a posterior convex border and the anterior concave border containing the hilum, with failure of rotation of the kidney. There is no medial border and lateral border. There is anterior and posterior border, like the fetal position. And there is failure of ascent of the kidney. This kidney at a lower position. Why? The kidney try to ascend on the posterior abdominal wall, but at the level of L3, this branch from the abdominal aorta will impact with the isthmus. This branch is called the inferior epigastric, inferior mesenteric. Inferior mesenteric artery arises from the aorta at the level of L3, leading to arrest of the horseshoe kidney below the level of L3. Renal pain. Renal pain is dull aching pain felt in the renal angle. What is the renal angle? This angle on the back of the patient, between the last rib and the lateral border of this muscle, which lies just beside the spinous process. Here is the spinous process, and this muscle is called erector spinae muscle. Between the lateral border of erector spinae muscle and the last rib, there is angle called the renal angle. And here, the renal pain is felt. Renal pain and severe renal pathology usually associated with nausea and vomiting. Why? Because the autonomic fibers in their way to form the renal plexus, renal nerve plexus, pass through the celiac ganglion, and celiac ganglion supply kidney, ureter, and the stomach. And severe pain in the kidney or ureter leading to reflex pylospasm, leading to nausea and vomiting. This is applied and the clinical anatomy of the kidney. Thank you for good listening and good luck.